Hey, good to see you again. Let's get started with our first patient.
Hi there.
This is Jim. He was diagnosed with ankylosing spondylitis a little over 1 year ago, and he's here to follow up.
That's right. I'm only 30 and I'm already turning into my dad, becoming a regular at the doctor's office. He's been dealing with IBD for years.
Jim originally came to us with back pain and stiffness.
Remember, my fingers and toes would swell up too.
Right. We confirmed Jim's AS radiographically and discovered that he is HLA-B27 positive.
Well, it looks like you've discovered 3 attributes for my case already.
Yes, we're moving right along.
But if you think we're too slow, don't forget that you can change our talking speed setting in the settings menu.
Right. Now, in a second, a blue triangle will start spinning over me.
Whenever you see one of those, it means you can select that person to gather more information and move forward.
So, Jim, are you currently having any symptoms?
No back pain or anything. Something weird did happen a couple months ago, though. I woke up and my right eye was all red. I thought maybe I got something in it.
Any pain or discharge?
It felt irritated, but no discharge. It was a little scary because I couldn't see right. Things were kind of blurry. Light was bothering me too.
Did you have an infection, or were you sick around that time?
Not that I recall. I was on vacation in San Diego, so I went to urgent care and they gave me a steroid drop. That seemed to help. It's better now. Are you thinking this was more than just something in my eye?
It could be. Has it ever happened before?
I don't think so.
Now, a white star has just appeared on the Meds button in the Case Info menu on the left.
Uh-huh. Whenever a white star appears on one of these buttons, that means that there's more information to be learned by selecting it.
That's right. Choose the button with the white star and we'll continue our discussion.
Oh, this is what I'm taking right now.
Yes, Jim has been on etanercept since he was diagnosed with AS. This is a summary of Jim's case. It'll be updated with new information as the scenario unfolds. It might be worthy of mention that Jim doesn't smoke.
Why is that?
Smoking can increase the risk for a certain type of eye inflammation. And that's a good segue to our first decision. The next step here is to decide if we can narrow our differential for your eye redness. Click Continue, and we'll move on to our first decision. You'll make selections in the simulation using a list of choices like this.
Just click on a choice to select it with the current silver orb.
Right. I agree. This doesn't seem to fit, as Jim's eye irritation sounds episodic in nature. Because you're on immunosuppressive therapy, we need to be cautious and not overlook the possibility of infection. But your symptoms improved with steroids, so I doubt that you had an infection.
Okay. That makes sense to me.
The takeaway here is that we can't exclude much without more information.
I guess there's more poking and prodding in my future.
Sorry about that.
It's okay. Whatever you think.
I'd like to order an ESR and CRP as a way of seeing how well the AS is controlled. I don't think any other testing will be helpful at this point. Hi. Here are Jim's lab results.
How do they look?
Well, they're elevated. His ESR was 20 and CRP was 1.2 the last time we checked.
So what does this mean?
Well, we still can't be sure what caused your symptoms. I'd like to come up with a plan moving forward, knowing that this could happen again. And that leads us to another decision. It looks like we need to decide on the optimal path forward for Jim.
So the orb won't have an X on it this time since we're not excluding anything.
Right, and there are going to be 2 green options here.
So once we get the first green orb, there will be another one after that?
That's right. What do you recommend? Yes, I agree. Jim, continue taking the etanercept for now.
Okay, sure. I just took my weekly dose this morning.
Although etanercept is associated with the development of paradoxical eye inflammation, I wouldn't make a change without finding out what Jim's eye condition is. I completely agree. We're lucky that we have Dr. Sarah Sims, a virtual ophthalmologist, available to consult with. Jim, if and when you have symptoms again, you should get in to see Dr. Sims within a day or 2.
Okay, got it.
Ophthalmology could see evidence of a past flare, but it's best for him to be examined when symptoms are present. Okay, Jim, if your eye symptoms return, do you know what you're going to do?
Sure, I'll get an appointment with Dr. Sims right away.
Great. Then we'll be back in touch if your eye symptoms recur, after you've seen Dr. Sims.
Okay, thanks.
For patients in this situation, an urgent, same-day visit with ophthalmology is the standard of care we should strive for.
That's right.
Oh, hi, Sarah.
Hi. Nice to meet you. I agree with Ian. If Jim's symptoms turn out to be an infection, we'd lose precious treatment time waiting around for an appointment to confirm what's going on.
Right. Of course, access to ophthalmology isn't always this easy. Sometimes specialties work closely within the same system, making the referral straightforward. But other times, these consults are much more difficult to arrange.
Thank goodness for virtual reality, right? We'll see you again when there are new developments with Jim. Jim came to see me this morning because his eye redness has returned, and he's reporting that his vision just wasn't sharp. I went ahead with an eye exam, and you can see those results here.
Did Jim have any pain or drainage?
Good question. No, he didn't have pain, and there was no drainage. In this case, the presence of a hypopion and posterior synechiae partially obscured my view of the retina, but the retina did not appear to be involved.
So the next step is to interpret the findings?
That's right.
Ready when you are.
How would you classify this? Yes, with hypopion and cells present in the anterior chamber. This would be categorized as anterior uveitis. Jim's case appears to be very severe and needs to be treated aggressively to restore good vision.
Does the location of Jim's uveitis help to confirm its etiology?
Yes, location does suggest a particular etiology. Let's discuss that next. You can click Continue when you're ready. Looks like we can narrow down our differential at this point.
This is a little out of my wheelhouse. What do you think is most likely?
Anterior uveitis is frequently associated with systemic disease, and with Jim's history of ankylosing spondylitis, this is what I'm thinking too. And as is true with Jim's case, HLA-B27 uveitis can be seen with lower eye pressures.
This is also supported by the fact that he's had recurrent episodes.
Yes, that's true.
Great. Jim will be happy to hear we have some definitive answers for him. I think our next step here is to decide on a treatment plan.
Agreed. Ready when you are. Once again, we need to make 2 choices here.
I have some thoughts. What do you think?
Yes, I agree. We often start with hourly while awake topical therapy. I'll see him back in a few days. If after 1 week we haven't seen improvement, we can move to oral.
Aren't there concerns about glaucoma and cataracts?
With long-term use, yes, that is something to keep in mind. Well, we could start with oral steroids, but because this is anterior disease, let's see if it can be managed with topical therapy first.
Exactly what I was thinking. We chose not to make a switch before knowing what was going on with Jim, but this does make sense now.
I agree. Once a patient has had uveitis, most clinicians are cautious about continuing etanercept. There are no data that compare etanercept to other anti-TNFs in this context, but we do know that etanercept is associated with paradoxical eye inflammation.
Because we have other options, we should choose a medication that is less likely to provoke another episode. Okay, sounds like a plan.
Our final decision will be to choose a different biologic for Jim.
Now we'll select 2 therapies. Let's use the first A orb for your preferred choice, and the second B orb for another viable option.
Remember, you can use the info eye icons to review the characteristics of each of these therapies before you make a choice.
Yes, infliximab is a reasonable choice. There is some evidence for its effectiveness under these circumstances, in active AS.
The downside is that it requires infusions in an infusion center and cannot be given at home.
We can talk with Jim about that. Sure, this would be fine. Adalimumab is approved for AS.
And non-infectious intermediate posterior and panuveitis. It was shown to extend the time to treatment failure to 24 weeks in the Visual 1 study.
Oh, this is interesting.
Yes, this shows you how your preferred choice compares to that of your peers for this same decision.
Great. So I'll discuss the options with Jim and get him on board with switching his biologic to either adalimumab or infliximab for his AS.
And I'll follow Jim's progress closely for the first week as he starts the steroid.
When he shows improvement, I'll see him every 3 months and monitor his ESR and CRP to assess disease activity.
Sounds good. You can click Continue when you're ready to wrap things up.
Before we continue to the synopsis, please test your understanding. Another response is more optimal. There is a more appropriate option here. Okay. Feedback is appreciated.
Wow, looks like we made it through this first scenario. Nice work.
Jim is doing better, and his uveitis has resolved.
Some patients will continue to have 1 or 2 flares per year, but hopefully we've chosen an optimal therapy and he avoids flares altogether.
One of the takeaways here is that having an awareness of iatrogenic causes of uveitis is important.
I would also add that navigating between specialists can be a challenge for patients. When a patient's condition is vision-threatening, it's very important to make sure they are connected with ophthalmology to receive urgent care.
Yes, and that holds true when patients present to ophthalmology first as well.
Sure. Just like with Jim's case, uveitis does sometimes turn out to be just one manifestation of a systemic condition that requires additional specialized follow-up.
In fact, we have another challenging scenario for you, and this one starts in ophthalmology.
Awesome. I hope you'll join us for that.